Assalamu alaikum. Bismillahirrahmanirrahim. Today, inshallah, we will start our mixed VIVA session. I am Dr. Muhammad Talat, Assistant Professor of Radiology at University. Inshallah, we will have a good number of cases, and I hope to see all of our cases. Let's start by candidate number 1. Are you ready, candidate number 1?
Assalamualaikum. Yes, sir, I'm ready.
Okay. I would like just to emphasize that if you want to interact with us, it's a free teaching session. And if you want to interact with us, you will find our link for our WhatsApp group in the first comment of this video. Okay. Okay. Candidate number 1. Okay, if you want to scroll, you can scroll. If you...
Sir, I will, I'm requesting for control.
Okay.
I've sent you request, sir.
Okay. Go
on. Sir, I will start from one end. So these are CT brain axial images of an adult. I'm taking a moment to scroll to go through the images once.
Okay.
I can appreciate that there is some undulation seen, some wavy margin seen along the ventricular lining.
Okay.
In the subependymal region, particularly in this section.
Okay.
The posterior horns of both lateral ventricles are also somewhat more prominent. Next, I would like to see other ventricular system, which is appearing normal. The basal cisterns are normal, and there is a normal orbit globe. Next, in my routine practice, I would like to see the other sections or post-contrast images, sagittal section as well, to see any associating ventricular. Sir, if I can go to contrast enhanced CT.
We don't have any contrast enhanced for this case, but I would like to add something is that this patient is pedia patient.
Is what, sorry?
Pedia.
Pediatric.
Yeah, pediatric, yeah.
Okay, so next I'm looking for the white matter and any cortical abnormality, any associated gyral malformation, because as it is a pediatric patient, I would like to consider two things. First, considering the wavy undulating ependymal lining, it could be tuberous sclerosis. So that has an association with cortical and subcortical tubers. And to rule them out, I need to see any calcific foci. There are some calcifications seen in this left transverse sinus region, but that usually doesn't have any association.
It's away from the abnormality, yes. Let's focus on the abnormalities that you mentioned before, that we have a corrugated outline. Can you please go to the lateral ventricles? Yes, here, please, yes. We have, just a minute. We have corrugated outline of the both lateral ventricles. And also, I think it's very obvious here. As you said, this one may be subependymal nodules, and you raised the possibility of tuberous sclerosis. Do you have any other differential diagnosis for the case?
Sir, other differential diagnosis, it can be in this location, in the pediatric age group, toxoplasmosis, but that has usually has some intrauterine history, and that has some focus of calcification as well. I would like to take
we
the
don't
history.
Have any calcifications, yeah, agree.
Yes, there's so next I would like to take the history of any developmental delay, any facial dysmorphia.
Epileptic fits.
Epileptic phase. So epilepsy and adenoma sebaceum, and this has an association with tuberous sclerosis. And next, I would like to see if the patient has any renal ultrasound to see any angiomyolipoma, because it has also an association with AML.
Okay. Would you like to make any brain imaging, any further brain imaging to
sir,
more
MRI,
characterization?
MRI.
Okay. I'm giving
particularly FLAIR.
Okay.
This is the T2 MR weighted image of the same patient, in which is redemonstrating my findings. There is wavy undulating corrugated margin in the subependymal region, and it has the signals which are showing the same signals as that of the cortical gray matter. If I see in this, so the signals of this gray matter and the signal of this corrugated lining, they are almost the same. So this means that this is so second option, second possibility can be gray matter heterotopia.
Yes,
or
you are right. You got the idea. Okay, so we have here classic case of gray matter heterotopia, and I think the CT image, as you said, we have subependymal nodules. We have two main differential diagnoses in this case, either tuberous sclerosis or heterotopia, and we don't have any calcifications, and clinical correlation is very important. Heterotopia can be manifested by epileptic fits, so heterotopia is the most logical thinking. So further, as you said, well done. Further MRI assessment was performed, and I think it's straightforward now. We have heterotopia case. Do you know which type of this one? Which type of heterotopia do you have?
So there are three types. It's focal, and it's under the ependymal lining, and it's band heterotopia. I think this is the second one. I don't know the exact name. And it has also association with mesencephaly, pachygyria, the whole spectrum, and which I would like to see in the flare.
So we have two main types, nodular type or diffuse type. And the nodular type subdivided into subependymal and subcortical. And this one is the subependymal type. And once we have heterotopia, we should look for any cortical malformations or cortical dysplasia or cortical abnormality. Associated cortical abnormality, we don't have any significant other cortical abnormalities. So we have nodular type of heterotopia. Okay. Thank you so much. And I'd like to add that heterotopia is caused by interruption of the normal neural migration from the ventricle to the cortex. Okay.
Okay.
Okay. Thank you so much. Can we go to candidate number 2, please?
Thank you so much, sir.
Okay. If you want to scroll off, or if you want me.
Yes, sir. I'm requesting remote control.
Okay. Go on.
Okay, sir. I'm provided with a CT scan, axial section.
This one is the post-operative status.
Okay, sir.
Yeah. Can you help me? Which operation? Can you give me details for this operation if you try to help me? Yeah.
Okay, sir. I'll scroll and I'll try to figure out. So there are mild bilateral pleural effusions are noted, and then as I scroll down, the kidneys, pancreas, liver, and spleen appears unremarkable, and there is oral contrast given, a positive oral contrast given. A pacification of the bowel loops is noted. Mild free fluid is noted, and then I can appreciate that there is a midline laparotomy scar, and then I can appreciate that there is mark thickening of the large bowel loop is noted, starting from the hepatic flexure involving the ascending colon, and there's a long segment of involvement. And as I scroll down, there is complex looking ascites can be appreciated. And sir, I've heard that the uterus is in place, and sir, it's a complex looking ascites, and then I can appreciate there is a long segment thickening of the large bowel with multiple.
So as you said that we have long segment of circumferential mural thickening involving the cecum and the ascending colon.
Cecum ascending colon, yes, sir.
Yeah. Okay.
So, I would like to correlate my findings with the history of the patient. I have
the history of the patient. That's the patient. Okay. So the site. Do you know? Can you? Yeah. Please help me. Is it what type of operation is this one, or can you give me any clue? Where is the site for this operation?
Sir, it is likely midline surgery. I would see the right iliac fossa and left side. It's a midline surgery. It's a midline pelvic or lower abdominal surgery.
I think it's localized at the right iliac fossa, maybe.
Okay, sir. Okay. Sir, I was looking for any standing and post-surgical changes in the right iliac fossa. Oh, yes, sir. Yes, sir. Now I can see this one. There is some post-surgical changes in the right iliac fossa.
Okay. There is incision in the
and there are some
right
collection in the muscle.
Yes, at the right side.
Sir, the surgeon might have operated for appendicitis.
Yes, you are right. This case, yes, this case. Really, I don't have great history for this case, but this one, this operation was done for appendectomy for complicated appendicitis, and this is post-operative CT scan for the patient 3 days after the operation.
Okay, sir. Sir, there is a complex-looking ascites, and there is long segment involvement
of the colon. Yeah, we have long segment of circumferential thickening of the colon. Do you have any collections?
Yes, sir. We have pelvic collections, complex.
Yeah, we have pelvic collections, and we have also peritoneal thickening. If you go, yes, this is peritoneal. Yes, we have peritoneal thickening.
Likely presenting post-op peritonitis and
yes, and locules of peritoneal. Yeah, locules or compartmentalization of the periton at the right iliac fossa and the pelvic region. And there is a smudging, severe smudging of the
fat, and also the colon, ascending colon. It is
okay, and we have also, I think, yes, we have also lymph node enlargement, some mesenteric lymph node enlargement.
There are actually lymph nodes in this region.
As you see here. Okay, so we have mesenteric lymphadenopathy.
Yes,
what do you think this complication? Sorry.
Sir, this is post-op infective post-op complication, colitis and
colitis. Yeah, I agree. Okay.
And complex ascites or Sir, if the patient has neutropenia, it could represent typhlitis too,
Okay.
for which I would correlate my findings with the clinical picture of the patient. And
Okay. The
sir,
patient, we don't have any evidence of neutropenia or chemotherapy or something. We don't have any history for this one. But I think let's focus on the peritone. Also, I think we have an evidence of peritonitis.
yes,
You
sir,
agree
yes,
with me
sir.
that we have
Yes, sir.
locules or peritoneal loculation and peritoneal thickening, and all of these findings are suggestive of peritonitis. And post-operative maybe bacterial peritonitis. Maybe this
Bacterial
peritonitis
peritonitis.
secondary for complicated appendicitis, maybe secondary for the surgical interference
Surgery.
itself,
Yes, sir. Yes, sir.
maybe. And as you said, we have here colonic mural thickening, most likely
Colitis. Yes.
colitis, maybe inflammatory, reactive inflammatory changes, post-operative, maybe infection, maybe, as you
Yes.
said, typhlitis, but we don't have any history suggestive of typhlitis, so we think for maybe pseudomembranous colitis, maybe
Yes.
secondary to appendicitis. I think this one is more logic. Once we have appendicitis, it can be associated with mural thickening of the
Secondary
SN.
to
Okay,
complicated
so
appendix. Yes,
yeah, so
yes.
this one is bacterial peritonitis as a complication,
Bacterial.
either from appendicitis or from the surgical interference. So can
Surgical
you please
complication.
wait me to see another case, please? Candidate number 2.
Yes, sir. Yes, sir. Yes.
Can you please see with me this case? Do you see
Yes,
this
sir.
one? We have
Yes,
another
sir.
case, and we have, as you said,
Sir, should
we
I
have
start?
peritoneal thickening, and we have peritoneal collections.
Omental kicking and bilateral ovarian masses
Yes.
and
Do you see any
okay.
more abnormality in this case?
Sir, there are bulky bilateral adnexa. Bilateral
Yes,
ovaries are
bilateral
noted.
adnexal
Then,
masses. Yes,
then
bilateral
sir,
adnexal
there's
masses, and
diffuse peritoneal thickening, loculated
yes, you are right.
ites, omental kicking,
Okay.
and sir, there is also peritoneal nodularity and no.
What's your opinion? You got all the abnormalities now. We have omental infiltrates, we have peritoneal thickening,
Yes, sir.
we have peritoneal collections, we have
Yes, sir.
bilateral adnexal masses.
But so can you show me the adnexal masses again? Okay,
Okay.
sir. If the patient is a young female patient with a history of fever and abdominal pain, my top
Okay.
referential would be abdominal tuberculosis, which is complicated by
Abdominal what?
ovarian abscess. Tuberculosis, sir.
I didn't hear you really well. Abdominal
Sir,
what?
tuberculosis, sir. TB.
Tuberculosis?
Yes, sir. And
Okay.
other
Okay,
differential
great.
would be some
Great,
neoplastic
great.
etiology.
Okay, so we have a differential diagnosis. We will discuss the differential diagnosis for this case later on, but this case proved to be tuberculous peritonitis
Yes,
with
yes,
bilateral
full blown
adnexal.
tuberculosis.
Yes, and these adnexal masses, what do you think this one?
So these are tuber ovarian abscesses.
Maybe, yes, TB, salpingitis,
Yes, sir. Yes.
making like soft tissue mass as the adnexal. Okay,
Yes.
let's see this case. This one also is proved to be, this another case with omental infiltrates and omental kick.
Kicking.
Yeah,
Yes,
proved
sir.
to be tuberculous peritonitis also. What do you think this one? This is another case.
Okay,
Apart
sir.
from the pyelonephritic changes of the post kidneys are small in size with cortical scarring, but we have also here omental
Sir, there is
infiltrates.
scalping along the liver surface
Can you go? Can you see this one? Yeah, I'm sorry. Yeah. Okay.
Yes, sir. Sir,
What do you think? Is there any more data you can add?
Sir, there is scalping also noted. This is looking to be more of a pseudomyxoma peritoni because of there is less inflammatory changes, less nodal thickening, and also there is ascites, loculated ascites, but there is scalping of the liver, and also I can say I have suspicion of the stomach wall thickening, which I would like to.
Very nice, very good. So you got the idea now. We have an irregular mural thickening
yes, sir.
along the laser curvature of the stomach, mounting to form, mounting to form mass lesion along
yes,
the
there are
stomach.
lymph nodes in the perigastric, pregastric region as well.
We have also some lymph nodes, perigastric.
Portal lymph
Right.
node.
So what's the logic thinking now? Peritoneal masses with gastric mural thickening.
Sorry, sir.
What do you think?
So this is diffuse peritoneal carcinomatosis.
Yes, peritoneal carcinomatosis, metastatic peritoneal masses. Yes. You are right. Yes. Okay. What about this case?
Okay, sir. Sir, again, there are loculated complex looking sir, loculated ascites, and so this is abdominal hydatid.
Very nice, very nice. Do you know that in my exam, the examiner showed me the case similar, so similar like this. We have multiple peritoneal cysts, and I think you agree with me that we have a larger cyst and daughter cysts. Yes, and this one is pathognomonic to be hydatid disease. What's your next step in this case?
Sir, I would sir advise echinococcus serology.
Yes,
and
serological confirmation. I agree. Totally agree.
yes, sir.
Okay. What about this case?
Okay, sir. Sir, again, I
To
can.
save your time, I'm sorry to save your time. We have
No,
like
no,
similar changes, but I think we have here like mural thickening along
yes, sir.
the wall of the small bowel.
Yes, sir. Long segment
You
thickening.
agree?
So, sir, can it be lymphoma? Because there is long segment thickening and diffuse
Yes.
thickening of small bowel.
Lymphoma?
Yes, sir. Lymphoma.
Yes, and we have also soft tissue lesions encasing the mesenteric vessels. Looks
Yes,
like
sir.
lymph node enlargement. So we have a case of peritoneal lymphoma. Yes.
Lymphoma. Yes, sir. Peritoneal.
Okay. I'm sorry to load on you, but okay, let's go
No,
to
sir.
this.
Okay, sir. Again, sir, there is diffuse peritoneal thickening, and
Okay.
sir, can this be primary peritoneal mesothelioma?
Okay, mesothelioma. Why you said mesothelioma?
Sir, because there is marked diffuse thickening involving the pleural cavity as well. And as we
Yes.
scroll it,
So we have here the key point that we have irregular mural thickening along the costal reflection of the pleura on the right
yes,
side.
sir.
This one is the key for peritoneal mesothelioma. Okay,
Yes,
and peritoneal mesothelioma and pleural mesothelioma most likely secondary to asbestos exposure. And peritoneal mesothelioma, it doesn't look like pleural mesothelioma. It doesn't show any calcifications. Okay, so take care of this one. Okay, this one also a case of this another case proved to be.
Okay, sir. Again, there's Omental thickening and complex looking ascites.
Okay.
And peritoneal seromental kicking is also seen. Sir, can you scroll down? Okay. So the bowel looks are grossly unremarkable. And sir, okay.
So this case, I'm sorry to disturb you, but to save your time, this one is considered one of the differential diagnoses for peritoneal thickening and omental kick, and this one was proved to be primary peritoneal mesothelioma without pleural mesothelioma. Okay, so I would like just to add something. If we have any peritoneal masses or nodules, we should think for peritonitis, bacterial infection, TB, as we saw before, hydatid disease, metastatic peritoneal carcinomatosis. The key points that you should search for any primary tumor. Zoodomyxoma peritoni, search for any appendicular masses or colonic masses. We have also primary peritoneal carcinoma. This one pathologically need pathological correlation. Peritoneal mesothelioma, the key points, we have two key points. Either you find pleural mesothelioma or pleural calcifications. Peritoneal lymphoma, if you have mural thickening along the bowel loop, and if you have soft tissue masses or lymph node enlargement along the mesenteric root, encasing the mesenteric vessels. So these are the key points for peritoneal lymphoma. Okay, thank you so much.
Yes.
Candidate number 2.
Thank you, sir. Thank you so much.
Thank you so much. Candidate number 3. Are you here?
Yes, sir.
Okay. Candidate number 3. Okay. Yes. Okay. Candidate number 3.
Yes, sir.
Yes. Can you scroll with me this case? It's a nice case. Also, we are dealing with peritoneal masses to complete this task.
Yes, sir.
Yes. Can you describe the
abnormality? Yes, sir. Sir, are you scrolling this? Yes, okay. So I am provided with CT scan abdominal images with contrast, and I could appreciate a lobulated mass noted in the right hemiabdomen. So can you please scroll down for me? Extending into the mid-abdomen as well. I could not appreciate any significant thick walls around this, and I could not appreciate any changes of surgery in the mid-abdomen. This is inseparable from the gall bladder and from the large bowel loop.
Okay. Do you think that we have any solid component?
No, sir. That's only cystic and fluid density mostly.
Yes. Okay.
Without any calcification, thick walls.
Maybe there is fine septations. Maybe this area has a fine septations. Maybe not. Okay.
Yeah.
I think we have here some
so
internal septations.
Yes, sir. So considering the appearances of a cystic peritoneal mass, I'm thinking of some lymphangioma as my first differential, and other would be some cystic met. However, they appear unlikely.
Okay.
Other would
would be low density mass cystic.
Yeah. Do you think that it is aggressive or not aggressive?
So I think it's not aggressive.
Not aggressive. Agree. Okay. So we have, as you said, we have the differential diagnosis for the cystic peritoneal masses. We have three main differential diagnoses. The most common is multicystic peritoneal mesothelioma. This one is a benign entity, benign tumor. Okay. And I think we have like multicystic mass with fine septations. We don't have any solid component, any enhancing solid component. So this one is proved to be multicystic peritoneal mesothelioma. Can you?
Multicystic peritoneal mesothelioma?
Multicystic peritoneal mesothelioma. Okay, this is the benign entity we will discuss now in the differential diagnosis. Okay, let me show you this another case.
Okay, sir.
Female patient.
Yes, sir. The ovaries are normal. The uterus.
Okay, the uterus is normal. The ovaries are normal also. What is the abnormality that we have?
I think so. There's a fluid present in the cul-de-sac. Loculated fluid.
Yes, loculated fluid. Yes, you are right. Loculated fluid at the pelvis, encasing both ovaries and extending to the douglas pouch. Okay, this one is proved to be peritoneal inclusion system.
Yes.
So let's see what's our differential diagnosis in our cases. Once we have peritoneal cyst or cluster of cysts, okay, we have three main differential diagnoses. Either multicystic peritoneal mesothelioma. This one is a benign tumor, as we said before, and we have also peritoneal inclusion cyst. Most likely peritoneal inclusion cyst located at the pelvis because it's most likely secondary to pelvic inflammatory disease. Okay, pelvic inflammatory disease, maybe salpingitis, maybe endometriosis, maybe something like this, making adhesions in the pelvis. And secondary, we have peritoneal inclusion cyst. Okay, we have also peritoneal lymphangioma. I have a case of peritoneal lymphangioma, but I couldn't give it to you now. But lymphangioma is small cystic lesion, maybe anywhere in the peritone, but all of these lesions are non-aggressive cystic peritoneal mass. Okay, so those are our differential diagnosis in the multiple peritoneal clusters of cysts. Okay, can you stay with me? Candidate number 3.
Yes, sir. Sure.
Can I give you one more case?
Yes, sir. Please.
Okay. Pneumonia. Yes. The referring physician requested from me to exclude pneumonia.
Okay, sir. So, sir, I'm provided with radiograph chest. First, I'm looking at the heart and the mediastinum, and they appear normal. The bilateral lung markings are also normal. I could not appreciate any opacity, consolidation, pneumonia, pneumothorax, or effusion within the lungs. Now I'm looking at the bones.
Yes, the chest is totally free.
Sorry, sir. Yeah, the chest is clear. The chest is clear. I could appreciate that there may be some catheter placed from the left side. The clavicles. I think they're fine. The bones are also fine.
That's good. Okay, very good. Okay.
I think the radiograph is fine.
Yes.
Sir, on the given, yes, sir. On the given provided sections, I could appreciate an opacity noted maybe in the right hemi-abdomen, causing a displacement of transverse colon inferiorly. Maybe it may be in a large liver. However, I would like to correlate with the cross-sectional imaging. It may be something from the kidney as well. As I could notice the inferior displacement of bowel loops. In addition to that, I could not appreciate any abnormal bowel dilatation. Only the transverse colon is prominent, with a prominent mucosal fold giving thumbprinting appearance.
Yeah, very nice. Very good. So you got
the idea now.
We have some printing, as you said, along the transverse colon. Very nice. And I think it was present here as a chest at the edge of the fin, as you see here. Please, my remark here for all candidates who will go to the FRCR exam. The FRCR exam, it's not difficult, but they play on the edge of the film. Maybe a simple case, but the modality, it's not diagnostic for this case, as we saw in the first case of heterotopia. It's easily diagnosed by MRI. He will give you the heterotopia by CT, not MRI. As you see here at the edge of the film, please localize, or you should pick up or go by your checklist and search for any abnormality at the edge of the film. Here the abnormality is in the abdomen, not in the chest. So take care of this one. And as you said here, we have some printing. Some printing, what does it mean, some printing?
So these likely represent edema and
some mucosal edema along the colon. Yeah, very nice. Okay, so we did for this patient CT scan to see what is this edema.
Okay, sir. Yeah, so there's significant.
If you want me to scroll, or if you want to scroll as you like.
Sir, I have requested remote control. I just want to practice the scrolling.
Go on.
Thank you, sir. Okay, so I'm provided with the CT images. I'm scrolling from the top to the bottom. First thing, I don't know it.
Okay.
But just give me a second. Okay, I could appreciate that there is significant thickening and submucosal edema involving the
Yes.
entire ascending transverse colon with
Okay.
that confirms my finding on the provided CT, provided X-ray.
Okay.
In addition to that,
Okay.
the rest of the visceras are fine. So considering the imaging appearances, I'm thinking of ulcerative colitis or pseudomembrane
Okay.
colitis as my first differential diagnosis. I think findings may be due to
Is the
pseudomembrane colitis.
colitis involving the right side or the left side mainly?
So it's mainly involving the right side and the transverse colon. The left side is pretty spared.
So we have the abnormality is localized at the right side of the colon, mainly at the right side of the colon, ascending colon and cecum, and going
Yes,
to the adjacent part of the transverse colon. But I think the
Yes,
ascending colon is totally free. Is it logic to think of ulcerative colitis?
No, sir. I think
Okay.
that the ulcerative colitis start from the rectosigmoid and then
Yes.
progress in a continuous
This is the
manner.
standard.
So
Yes,
I
this
would
is the ideal pattern.
like to.
Yes, agree. Totally agree. Okay.
So, sir,
So what's your
maybe
differential diagnosis?
so some infectious colitis like salmonella or
Okay.
Shigella, and the other would be the pseudomembrane colitis.
Okay. What did you say at the last point?
So
What's your
pseudomembrane?
pseudomembrane colitis? Yeah, very nice.
Yes.
How can we differentiate from your clinical data? If you have this case in your exam, I think you should ask the examiner
Patient is on
some
antibiotics.
points,
Or...
some tips in the clinical history. What will you ask me?
So if the patient has any recent history of hospitalization or antibiotics.
Okay. No.
No. Then I'm not sure.
You should ask me. Yeah, if you have something in the ascending colon, you should ask me. You should think of typhlitis or pseudomembranous colitis. Those are the main two differential diagnoses. Typhlitis, you should ask me if the patient taking chemotherapy, if the patient leukemia, lymphoma, if the patient is immunosuppressed. Okay, if the patient has history of neutropenia. We don't have any history of neutropenia as this case. So you should ask me, is the patient, did the patient take a long-term history of antibiotics or not? If the patient taking a long-term antibiotic or there is history of past history of using antibiotic for a long period with diarrhea, these are pathognomonic or can help you to diagnose pseudomembranous colitis Clostridium difficile. Okay, so this case really when I asked the referring physician about the antibiotic, I found that the patient was received a long term of antibiotic, and this case was proved of pseudomembranous colitis. And let me go with you to another case, please, if you want. Do you want, or you want to stop here?
Sir, I want to.
Okay. Okay. This another case of, I think it's classic sun printing appearance involving the transverse colon and and the hepatic colonic flexion. If you have something like this, you will say, I have some printing denoting submucosal edema of the colonic wall. It's a long segment, so my logic thinking will be colitis. Okay? Okay. This another case.
Okay. So I'm provided with CT scan.
Yes. Okay.
Images. I could appreciate mild bilateral pleural effusion, and there is significant thickening noted in the cecum and the ascending colon.
Yes.
That there is mild stranding as well, along with thickening of the peritoneal fascia.
Okay.
Third, the ileocecal junctions. Can you show me once more? It's partly involved, but dilatation is spared. The disease is primarily centered in the cecum and the ascending colon. The transverse colon itself is fine, and the descending colon is also fine. There is significant surrounding prominent vessels and the mesentery. The appendix is also slightly thick-walled and enhancing. It may be the primary cause, or it could be reactionary due to involvement of the.
So again, as you said, we have circumferential mural thickening along the ascending colon and cecum, and as we said before, this is our differential diagnosis for any colonic sun printing. We should think of colitis, either infection, Clostridium difficile, pseudomembranous colitis, cytomegalovirus, and inflammatory ulcerative colitis. Both of these can involve the whole colon, can involve to make pancolitis. Okay, ischemic colitis can take any segment of the colon. Iatrogenic, secondary to radiation or graft versus host disease, and this one occurs in bone marrow transplantation. So we have 4I. If you are in the exam and you are for a little bit confused, think for 4I. 4I, infection, inflammatory, ischemia, iatrogenic. Okay, those 4I can involve any part of the bowel. Infection, inflammatory, ischemic, iatrogenic. As we said, Clostridium difficile and ulcerative colitis can involve the whole colon. Ischemic colitis can involve part of the colon, iatrogenic also part of the colon. Okay, so I would like also to add something very important. If we have right-sided colitis, we should think of 2T, typhlitis, and TB and Crohn's. And this one, if you have any abnormality at the ileocecal junction and thickening at the ascending colon, we should think for TB and Crohn's. Amoebiasis and appendicitis. This one is very important. As you saw with me the first case before, that we have a case of complicated appendicitis and we have thickening of the ascending colon. So we should think of appendicitis, typhlitis. Those are the most important. Transverse colon, E. coli. Left side, we have 4I, and especially ischemic colitis at the watershed areas between the superior mesenteric and inferior mesenteric, located at the splenic flexure. Also the watershed area between the inferior hypogastric vessels and the inferior mesenteric artery, located at the rectal segment. Infection, Shigella and schistosomiasis involving the rectum and can extend to the left side. Iatrogenic also. We have two special differential diagnoses at the left side of the colon, either diverticulitis and epipleural abscess. So those are the differential diagnoses. How do you think that if we have a case of colitis? Another differential diagnosis is other causes, other rare causes, either amyloid, lymphoma, and metastastic. Okay. Before finishing this point, I would like to just to add something very important in our case. Okay. This case, as we said before, we have pseudomembranous colitis. Do you know what is this sign? What is this sign? Do you know?
Accordion sign.
Accordion sign. Very nice. Perfect. This accordion sign is one of the signs that can suggest pseudomembranous colitis. Okay. Thank you so much. Can we move to candidate number 5? Is that correct?
Candidate number 4, Doctor. Yes, I'm here.
Number 4.
Also, candidate 4 is when I was candidate 3, and thanks so much for.
Thank you so much. Okay.
Me, Doctor, please.
Okay, no problem.
So this is abdomen and pelvis CT scan with oral and IV contrast enhancement in the portovenous phase.
Yes.
There is an inflamed bowel loop within the right inferior fossa. Could we focus on that region first?
Okay.
Okay, I'm trying to identify where it is arising from. It appears to arise from the cecum. It contains multiple calcified areas, probably
Yes.
at megalith. So this is most likely acute appendicitis. I'm
Very
trying
nice.
to identify any complications surrounded by marked fat stranding.
Very nice.
I'm trying to identify any complication like perforation. There's a phlegmon around it, but there is
Yes.
no collection, organized collection.
Okay.
Multiple lymph nodes in its vicinity. I'm trying to see if there is any air outside its lumen. There appears to be none. No pneumoperitoneum. If there is any venous thrombosis or abscesses within the liver.
Very nice. Very
Okay.
nice. Okay.
Yes.
So
And
those are the most important negative findings that you should mention. Okay. Again.
Yes.
Okay. Complete. Okay.
Yes, I will also scan the entire slices to check if there is any other abnormality. Any reactive ileus is also could. No reactive ileus. Okay. Any incidental finding? There appears to
I
be.
think also we have a
none.
few mesenteric lymph nodes.
Yeah,
as you see
yes,
here.
I mentioned those. Yes, Doctor.
Yeah,
Yes.
you mentioned. Okay. So I think you collected the most important findings. We have tubular structure, and this
Yes.
tubular structure, if you measure this one, I think it is
Related. Yes.
it's more than I think about 2 centimeters.
Yeah.
And I think the normal dimension
should be less than 8
should be
millimeter or
less than
centimeter.
6 millimeter. Okay, so
Okay.
this is markedly enlarged appendix, and you should be sure that this one is appendix. If you go
Yes,
to the
blind
connection,
ended.
yeah, it's
Yeah.
it's connected to the cecum.
Cecum.
This is the cecum. Okay.
Yeah.
So yeah, you should be very clear. Is it Meckel's diverticulitis or appendicitis? Okay.
Yeah.
So this one
Okay.
is, as you said, we have appendicitis and it's surrounded by phlegm. And I think, as you said, we have also two or few appendicules inside the appendix. And
Yeah.
as you said, we have mesenteric lymphadenitis, and we don't have any venous thrombosis, mesenteric venous thrombosis or portal vein thrombosis. This is
Yeah.
one of the most negative important findings, and we don't have any evidence of pneumoperitoneum, and we don't have extraluminal air. What are the points or the signs that you should mention to differentiate between perforated and non-perforated appendicitis?
The sure signs are extraluminal air, around
Very
the
nice.
appendix.
One extraluminal air.
Yes, yes. Sometimes a defect in the wall with adjacent collection
Very nice.
would also
Okay.
be a clue.
Okay.
Okay, sometimes if there is an enhancing area within the wall of the appendix, you can suggest a gangrenous appendicitis, but
Okay.
not all the time it must be perforated. It can be gangrenous
Okay.
without perforation.
Okay. Okay. So we have
If
five
there is a
signs.
also appendiculus outside the
Yes.
appendix, yes.
Yes. Extraluminal air, one. Extraluminal appendiculus, two. We have also defect in the wall, phlegmon, and the last point is retroperitoneal inflammatory changes. Okay. So this one proved to be impending rupture appendicitis, and I would like to share with you a small point here, if you are interested. Yes. This is an article that I published on 2016. How can we differentiate between the non-perforated and perforated appendicitis? If you are interested to watch this one, you will find some interesting cases to differentiate between perforated and non-perforated appendicitis. Okay, let's move to next case.
Yes.
Keep with me. Okay.
Yes, I am with you, doctor. Yes.
Okay. Okay.
Okay, so this is an abdomen X-ray for a child.
Yes.
There appears to be a soft tissue density, a large soft tissue density within the abdomen, more to the left side, displacing the bowel to the right.
Yes.
I can't see a definite extension of the soft tissue density into the pelvis, so it is probably not arising from the pelvis. I can't for sure define if there is any silhouetting of the kidney or not. To define if it is retroperitoneal, but I think it's intraperitoneal as it displaces the small bowel, not retroperitoneal. But I would go for.
I'm sorry to disturb you, but the retroperitoneal mass, if it is very large, it will displace.
Okay. So I would go for abdomen and pelvis CT with contrast enhancement.
Okay. What's your differential diagnosis in this case?
For a large mass in a child, I would think about neuroblastoma.
Okay.
Wilms tumor is a possibility as well.
Yes.
Okay. What else? If it arises from the pelvis, there would be a wider differential diagnosis like dilated urinary bladder due to BUJ or etc., multiple causes, neurogenic bladder, etc.
Okay.
So
soft as you said, you did very well. Okay, so we have large soft tissue density located at the left side of the abdomen and displacing the bowel loops to the right side. And this in this age group, pediatric age group, I think this one maybe 5 years, maybe something like this, maybe 4 years. In this age group, you should think for 3 main causes: either neuroblastoma, Wilms tumor, and also I would like to add cystic nephroma.
Okay.
This one, so we should localize the kidney and suprarenal glands. Okay. Also maybe multicystic dysplastic kidney, but this one will not take this huge size of soft tissue lesion. Okay. So those are the main differential diagnosis. As we said, the next step to do CT abdomen and pelvis.
Okay. So this is
I'm sorry.
Take your time, doctor. Yes.
I'm sorry. Okay. Let's go to the CT cell and let's see what do we have.
Okay, so
let's see.
Yes,
this CT scan for the same patient.
Yeah. Now it's clear. Yes, this is a contrasted abdomen and pelvis CT scan, IV contrast in the portovenous phase. There is a heterogeneous, large soft tissue mass, cystic component and solid component, both are present. I'm trying to determine where it arises from. Okay, so I'm checking the right kidney and right adrenal gland. It appears to arise from the right kidney as there's
from the left kidney.
From the left kidney, sorry, as it appears there is some close sign within the left kidney.
Yeah, very nice. I want to see this. This is a close sign, as you said.
Yes.
This is the most important point to differentiate. This is a mass. Okay. And this is a close sign. So we have this mass arising from the left kidney. And I think you got the diagnosis. What is your diagnosis in this case?
I'm thinking about Wilms tumor as a top differential diagnosis.
Okay, so you should also Yeah, you should also comment on the vessels.
Yeah, I would check the. It appears
Yeah,
that
check the
the
vessels and
peritoneal
check the
vein is
bone.
not
Yes,
very
yes,
clear.
very
The
nice.
lung, yes, and the bone, yes.
Yes, very nice. Yes, okay. Thank you so much.
Most welcome.
Candidate
Thank
number
you so
4.
much.
Can you go to the next candidate, please?
Yeah, for sure.
Yes.
Sorry.
Yes.
Can
Next candidate. Are you
Yes.
ready?
Yes.
Okay.
Yes, doctor.
Okay. I think yes. Okay. It's very nice and straightforward. Yes.
Okay. So I've been provided with axial cut CT for chest with
Yes.
contrast. Just I am looking for the blood vessels.
Mm-hmm.
Okay. Left atrium appearing normal. Okay, and veins also appearing normal. Just I want to
Okay.
look for yes. Okay. So I can see also right coronary artery appearing normal, left coronary.
Is the right coronary appears normal?
Just can you go back, sir? It's arising from the left.
Yes. You are
yes,
right.
from the
Yes.
left. So yes, this
Yes,
is a
it's
congenital anomaly, and I
yes.
think this is called malignant course,
Yes,
and
malignant
it
course.
means
Yes.
yes,
This one is a malignant course of
yes,
the right coronary. It arises from the left coronary clasp, not from the right coronary clasp, and passing between the ascending aorta and the pulmonary artery. And this course is interarterial course. And
yes,
this is one of, it's considered as a malignant course and
because
have a
it
risk,
will be
have
compressed,
a risk
yes,
to
for the
occlude
sudden
this
death.
artery
So we should
and
yes,
can manifest by acute myocardial infarction along the right coronary artery. Okay, very
okay.
nice. Okay, can you?
Okay, this is the frontal.
I'm sorry. Just a minute. I am sorry.
Okay.
Okay, but okay, I don't know why it's this case. Okay, anyway, let's see what you have.
This is the
Yes.
frontal radiograph of immature skeletally patient
Yes.
for chest and abdomen.
Okay.
Just I will have a look. I don't know about the history of this patient, but I will have. Sorry.
I'm sorry. Okay.
Just I will have a look for the chest first.
Okay.
I can see that heart and mediastinum appearing normal, and also both lung parenchyma appearing normal.
Okay.
I will have a look for the bone. I think that I believe that the bone slightly is diffuse sclerosis.
Yes,
diffuse
very nice.
sclerosis.
Okay. Yes.
And also the left humerus showing fracture in its upper shaft.
Okay.
Okay, just it's appear to be okay, and only there is no more. Okay, just 1 second, Doc. Okay.
So you did very well. You have a case, pediatric case,
This case
and
of
we have
pediatric
increase bone
the bone
density.
density of of all the bone symmetrical bone
Yes.
density increasing. It could be osteopetrosis.
Okay.
Also with this pathological fracture, as it's marble bone disease, so it show a
Very
lot of
nice.
fractures.
So we have here fracture
Yes.
and
Yes.
the upper humeral shaft.
Yes.
Okay.
I would look in all the other bone just to be sure that's diffuse sclerosis in the osteopetrosis, and also I would have look for the jaw.
So your differential nose is osteopetrosis. What are the other differential nose?
For diffuse sclerosis?
Yes.
I think, as I remember, just it could be pycnodysostosis.
Pycnodysostosis. Very nice. Okay. Those are the main differential nose. Okay.
Yes, it could be fluorosis also.
Okay. Okay. So can you see with me this another case? I think this is more obvious. What do you think this case?
This case is again diffuse bone sclerosis.
Yes.
Bone. It's again osteopetrosis.
Yes, and we have also metaphyseal leucissus.
Yes.
Okay. Okay. Osteopetrosis can be one of our differential diagnosis in this case, and I think if we go to our differential diagnosis, in this case, generalized increased bone density in the media age group. We have osteoporosis and pigmentosis. Those are the most important. We have progressive diaphyseal dysplasia, also renal district, fluorosis, lead poisoning, hypervitamin D, and other less common depression levels. I need to highlight very important point that if you want to differentiate between osteoporosis and pigmentosis, as we have in the last case, which type of exam? Which type of exam do you want to request to differentiate?
Jaw X-ray, mandible.
X-ray, which X-ray mandible? Okay.
The pigmentosis will be wide angle.
Okay, wide angle. Okay. For the mandibular angle. Okay. What's
yes.
more? X-ray for which part?
I couldn't remember.
X-ray hand.
Okay, hand for in the in the pigmentosis. Yes, it would be there is maybe hypoplastic
osteolysis. Okay.
Yes.
For the
okay.
hand, also chest X-ray
would be there is wormian bone. Maybe there is would be
X-ray poster. Yes. So those are the differential diagnosis. If we do skeletal survey, you should focus on the hand, chest X-ray, and stuff. Okay. Of course, as you know that the bone appears sclerotic and thick and loss of corticomedullary differentiation, but at the same time the bones are weak and brittle and easily broken. Okay, so those are our differential diagnosis in this case. Thank you so much. And number 5, can we go to the next scan, please?
Assalamualaikum, sir.
Yes. How are you?
Alhamdulillah, sir. How are you?
Alhamdulillah, fine. Okay, is that clear for you?
Yes, sir. I'm not able to scroll. Sir, should I request? Okay, sir. Sir.
Yes.
X-ray chest frontal projection of a mature skeleton.
Yes.
In which I can see the bilateral lung fields that appears predominantly okay. The heart size is okay. I am not. The CP angles are normal.
Okay.
The bones appear grossly unremarkable.
Okay.
Sir, sir, there is a subtle area of increased opacification in the right paratracheal region. If I am able to get the control.
Yeah, go on.
Yes, sir, I requested.
Okay.
Sir, this area, sir, are you able to see which I'm pointing?
Yes. Yes.
Sir, a subtle area of increased opacification noted in the right paratracheal region.
Okay.
I would, and apart from that, there's a few atelectatic bands in the left lower lobe. And rest, grossly, the rest of the things appear unremarkable. I would like to know the history of the patient.
Okay. Cough. Chronic cough.
Chronic cough. Sir, although I'm not able to appreciate any gross abnormality in the lung parenchyma elsewhere, so I would like to advise for CT chest.
Yes, very nice. Okay, so you got the idea now? Yes, one of the hidden areas, lung apices behind the clavicle. Take care of this area, and take care of. I have within my checklist. I should comment on 3B. Behind the heart, look for behind the heart, below the diaphragm, and the breast shadow. Okay.
Yes.
And also we have some hidden areas. The lung apices, one of the hidden areas in my checklist, and this is pulmonary opacity. Need further evaluation. Let's see what you have here.
Yes, sir. I'm appreciating speculated irregular mass lesion in the right apex. With subtle internal areas of cavitation, you can say, or like I would like to see more on the mediastinal window.
Okay.
And it is speculated, and it has had certain architectural distortion in the surrounding lung.
Very good. Okay.
I would like to further see, and in an adult person, the topmost differential will be a CA, a pulmonary nodule, likely carcinogenic. So I would like to see advice for the CT chest, abdomen, and pelvis for the further workup, metastatic workup, and inform this finding to the referral physician, and for the MDT meeting for the staging. Yes,
you did very well in this case, really. Just I would like to add one tip in this case. You said that we have surrounding architecture distortion, and also we have pleural traction.
Yes.
Do you know this sign?
Pleural traction signs, or
what is the name for this sign? This one.
No, sir, I don't know, sir.
Tail.
Pleural tail sign. Okay, sir.
Tail sign.
Thank
you.
Okay.
Thanks. One of the most important signs. Okay.
Yes, sir.
Okay, thank you so much. Can you go? Can we have another candidate, please?
There only one case for me?
Do you want another case? Okay, go on.
Yes, sir. You showed so many cases.
Okay, I'm sorry. Oh, I'm sorry. Okay, yeah, you saw with me one case only, sir.
Yes,
okay.
yes.
Okay, Lala, go to another case. Okay, I will give you 2 more cases, not only one.
Yeah,
case.
yeah,
Okay.
sure, sir. Please.
Okay, go on.
There X-ray pelvis of an immature skeleton,
Yes.
frontal projection in which grossly I'm not able to appreciate any fractures, but
Okay.
I may, what I see is actually generalized decrease in the bone density, more so in the more oriented around the hip joints. Like there is increase in the tuberculations, although I am not able to appreciate any cortical break in any of the bones.
Okay.
SI joints are normal.
Okay.
No evidence of any avulsion.
I think this age group is adolescence age group. Do you agree?
Sir, just fused epiphyses, but a few of them are not fused. So, sir, it is like immature skeleton.
Yes, immature skeleton. Yes.
So, sir, I would like to know the history, if there is any history of bilateral hip pains.
Yes, hip pain.
Hip yes, pain. Sir. So, sir, sir, I would like to know on the left side, if it can be, then I would also like to have a view that whether this is avulsed or it is just unfused.
Okay.
And apart from that, my other thing that I notice is actually the reduced density and there is fuzziness or haziness along the cortical margins of the hip. So okay. I would like to.
Okay. The pain is localized at the left hip joint.
Yes, sir. So these two things I find abnormal, because here the tuberosity look fused, but here it looks unfused. There, so it could be or could not be an avulsion. And apart from that, my concern will be regarding the irregular cortical outline of the femur. And I would like to know if there is. I would like to refer this patient for ultrasound to see if there is any underlying effusion or synovitis going on, and then further confirm my finding to the referring physician, and also ask for.
The iliopsoas fat planes here is similar to here. I think we don't have any cross joint effusion. In this age group, at the hip joint, left hip pain, can you focus on the head and neck itself? Can you focus on the physis? Can you compare the physis left side with the right side?
Yes, sir. So there is mild increase in the distance along the medial aspect of the physis as compared to the left side.
Sir, for a little bit, it's widened as compared to this one.
Yes, sir.
Do you agree with me?
Yeah, I totally
agree. A little bit irregular. And what do you think?
It could be a slip capital femoral epiphysis. I would like to have a yes, sir. I would like to have a probe.
How can we confirm? Yes, go on.
Yes, sir. First of all, we have to there is a line called Frankel's line that we draw, and it should.
We have line of Klein. And line of Klein. This is a normal line along the superior aspect of the femoral neck.
Exactly.
Should intersect the femoral head. If we start to draw this one on the left side, I think
it doesn't
intersect. Yes, the femoral head, because it's slapped posteromedially. I think also if you want to ask probe position, it will be much better and easily. Yes. Can you show? Yeah. Can you describe this case? I think it's as you said, this is another case of slipped capital epiphysis at the right side. Yes, and the femoral head looks like smaller in its height.
Flattened and smaller and slipped.
Yes, and slipped.
It looks like bilateral slipped capital epiphysis.
I think it's on the right side. The left side it's normal. It doesn't looks like slip. Let's see in the lateral view.
Yes, it is like very evident on the lateral view.
Okay. Yes, it's a frog-like. Line of Klein should be applied on the AB projection, not on the frog position. This is one of the important tips. Also, we have if you see or localize here, this area here is more sclerotic than the rest of the femoral neck. Do you know what is the sign?
Yeah, sir. This no, sir. I don't know this sign.
This is what we call the metaphyseal clench sign.
Metaphyseal clench sign. Okay, sir.
Yes. Okay. This one is very important because the femoral head itself, the head or the epiphysis rotated posteromedially and overlapped posterior to the neck, femoral neck, and this overlap between the bones can create this sign. Okay. Just we need to add some tips also. In case of slipped capital femoral epiphysis, you should comment on the complications. What are the most common complications for slipped capital femoral epiphysis?
Sir, it can lead to perthus. It can lead to AVN if it is not fixed. Yeah, osteonecrosis of the femoral head.
You should comment I don't have any evidence of osteonecrosis at the femoral head. Okay.
Yes, sir.
Okay. Just I would like to add something. It's not important for the exam, but it's important for a little bit in your routine life. We have something called lateral epiphyseal shaft angle. We will draw a line parallel to the epiphysis, and we will draw a line perpendicular to the first line, and we will draw a line along the shaft. Here, the angle between the two lines, the line perpendicular to the epiphysis and the line of the shaft, normally should be 0 angle. Here in the slipped capital femoral epiphysis, we will draw this line first along the slipped epiphysis, and second, we will draw the perpendicular line to the first line, and we will draw the third line along the femoral shaft. And this angle between both of these lines, this angle between this line and this line is called lateral epiphyseal shaft angle. Normally, it should be 0 angle, but if we have from 0 to 30, this is the first grade of slipped capital femoral epiphysis. From 30 to 50, second grade. More than 50, it is considered as a third degree of slipped capital femoral epiphysis. Okay. Thank you so much. Let's move. I think also I would like to add some tips here. MRI is very important to confirm the diagnosis and to check the contralateral side and to exclude any complications of osteonecrosis. And the management is by pinning in situ. Pinning in situ means fixation in situ. We don't have to reduce the femoral head to its place again, okay? For fear of shearing injury for the vessels and for a risk to develop osteonecrosis, okay? Thank you so much.
Thank you, sir.
Let's move to the next candidate. Young adult patient. It's not so young. Okay, go on.
Okay, I'm presented with axial cuts of CT scan of the brain in a young adult brain window. I can see that there is an abnormal hyperdense area in the right temporo-occipital region surrounded by hypodensity in the subcortical white matter of the right temporoparietal lobe. I want to trace the area of the venous sinuses to look for evidence of hyperdensity. The hyperdensity actually is in the anatomical location of right transverse sinus, extending to the right sigmoid sinus.
Yes.
So I'm thinking
you
about...
have here, as you said, let's conclude what you say. We have distended transverse sinus and dense. Yes. And we have also the sigmoid sinus also is dense. And I think we have also the internal jugular vein itself. It's dense as compared to the left side. Okay.
Yes, you are.
Okay.
So I'm dealing with dural venous sinus thrombosis with a possibility of associated venous infarct on the right side.
Yes, you are right. So we have cortical or gray-white matter interface is lost, and we have wedge-shaped area at the right temporal region. And I think we have also a hemorrhagic element here.
Yes, hemorrhagic internal changes.
Yes. We have hemorrhagic venous infarction secondary to dural sinus thrombosis. Also, we have if you can concentrate more, this is cortical vein
thrombosis.
Yes, you are right. How can we manage this case?
This is an urgent case, so I should urgently pick up the phone and convey my findings to the referring physician. They should initiate anticoagulant treatment. Before that, the patient should underwent an CT venography or MR venography.
MR venography, okay.
Yes, and then anticoagulant treatment.
Anticoagulant therapy, yes, very good. Okay,
with the follow-up.
Yes, let's move to next case. This is a young adult patient, 22 years old.
I'm presented with axial cuts of brain MRI of a young adult patient.
If you want to scroll, do you want to scroll?
No, sir. I hope that you can scroll for me.
Yeah, okay.
I can't.
Okay.
In this non-enhanced CT scan of the brain axial cut, there is a well-defined lesion involving the pineal gland area. There are multiple foci of calcification centrally located within the mass lesion, which appears to be of heterogeneous density and causing mild prominence of both lateral ventricles and third ventricle as well. I want to correlate with the post-contrast study as well as the sagittal cuts to confirm the anatomical position of the lesion. In correlation with the patient's age, young age male, I'm thinking about pineal gland germinoma because of the pattern of engulfed rather than burst out calcifications.
Is it engulfing or not engulfing the calcifications?
It appears to be within the center of the lesion. This is the pineal gland calcification, the large one. The smaller one is located somewhat within the lesion, but a bit peripherally.
Okay.
So it can bear the differential diagnosis of pinealoblastoma.
Okay. You did very well, really. We have a relatively large space occupying lesion, heterogeneous space occupying lesion, located or centered at the pineal gland, and it shows peripheral mainly peripheral calcifications. And do you have any more abnormality?
I have to check the suprasellar area because of the possibility of concurrent lesion, and I also should look for presence of CSF seeding, and this should be checked on post-contrast scan.
Okay, very nice. Okay, what do you have?
So in the sagittal cut, I can see the same lesion in the pineal region with peripheral pattern of calcification, causing a pressure effect on the midbrain and causing also hydrocephalus. There is an extra-axial lesion. Also, this is the superior sagittal sinus. I don't know. There is like an extra-axial CSF collection in the frontal lobe.
Yes, you are right.
Yes,
you are
there
right.
are
We have
defects
here
in the
another
skull.
collection, subdural collection at this area. Agree. And
Yes,
also we have the mass.
evidence.
Yeah, just I would like to add that the mass lesion is invading the dictum. This is the dictum of the midbrain.
Yes.
Okay. And once we have a pineal gland mass involving or infiltrating the dictum, which syndrome would be expected to be
Perinoid syndrome, which is upward gaze palsy.
Upward gaze palsy and also pupil dysfunction. Okay. Okay.
Yes.
Very nice. As you said, that we should search. Next step, we should search for CSF seeding or leptomeningeal metastasis. Do we have any leptomeningeal metastasis?
I cannot judge on a native scan. So I have to check the post-contrast scan to see for any abnormal leptomeningeal enhancement. Regarding this extra-axial collection, it is associated with defects in the overlying skull. So could it be due to previous shunting, for example? There is also a focus of air in the intracranially.
Where is this area? I didn't find this area.
In the extra-axial collection.
In the extra-axial collection itself?
Yes, just again. A bit more laterally. Okay.
Okay, let's see again, please.
And the high convexity.
Yeah, this one is a fair hole.
This bone defect, but I mean higher, the highest top on the cranial vault.
Okay.
There was a single focus of intracranial air.
This area, maybe not.
It's just down below.
We have subdural collection, as you said here.
Yeah.
At the right frontal region, and I think also we have small area, a small hypodense area at the frontal region. Maybe what is this one? Do you know?
This is the tract of the shunt.
Tract of shunt. Yes, you are right. Okay, so this patient most likely had prior shunting. And do you have any more extra abnormality? Is there any hydrocephalic changes?
There is mild dilatation of both lateral ventricles.
I agree with you. Okay. Do you have any more abnormalities?
I
am sorry that the patient, the CT scan was done without contrast.
Okay.
But let's try together to find any more abnormalities.
Find any more? Okay. And both thalami, there is odematous changes, or I think it's mass effect on both thalami.
Okay.
Apart from that, there is same lesion with the calcification seen peripherally.
Do you agree with me that the ependymal lining of the ventricles are slightly
thickened? Yes. Yeah. Mainly at the frontal, at the frontal horns of both lateral ventricles. This
How can we explain this one?
Yes, this can be correlated with the extra-axial collection and the history of shunt, that there is an extra-axial abscess and associated ventriculitis as a complication for the CSF shunt.
Yes, maybe complication of shunting, maybe ventriculitis, sequelae of chronic ventriculitis, maybe CSF seeding.
Maybe CSF
seeding. Maybe post-radiotherapeutic sequelae. Maybe those are the most likely explanation for this area. Yes. Also, I would like to add something here that in the sagittal plane, I think the infundibulum itself, it is thickened.
Yes.
This area. What do you think this one could be?
It could be another germ cell tumor.
Maybe. Or maybe CSF seeding itself.
Maybe autoimmune hypophysitis.
Because this one is characteristic location for leptomeningeal metastasis. I think also we should comment on the orbits. No retinal masses.
No mass lesion.
We don't have any evidence of retinoblastoma.
Yes.
Or evidence of previous retinoblastoma.
Yes.
So I think, as you said, our two top differential diagnoses, either germinoma or pineoblastoma. Pineoblastoma occurs at younger age.
Yes.
Most likely before 10 years, something like this. 5 years, 7 years, something like this. Germinoma most likely to appear in this age group. But at the same time, germinoma, the classification is most likely to be at the center. Pineoblastoma,
yes, will be
from
peripheral.
the B, it is peripheral.
Yes.
Memorize yourself, peripheral classification, B and B. Okay. Yes. Also, the next step, you should do MRI for the whole spine with contrast, for the whole neural axis to exclude leptomeningeal metastasis. Okay. That's good. Our differential diagnosis in this case also pineal meningioma, pineal metastasis. I think a pineocytoma, it's far away because pineocytoma is most likely cystic mass. predominantly cystic mass. Okay, I would like to add something. It's not so important, but do you know this is a third ventricle, and we have here two recesses. Do you know the name of this recess because it's dilated because of hydrocephalic changes?
There is infundibular recess.
Okay.
And
this one is supraoptic recess, and this one
and
is
infundibular
suprainfundibular recess. Yes,
Yeah.
you're right.
Yes.
Very nice. Thank you so much.
Thank you,
Candidate
sir.
number 8. Can we have candidate number 9?
Yes, hello.
Hello, how are you? I'm sorry
I'm-
you waited too much to share with us, and I think this is a long session. I am so sorry to stay
No
with you
problem.
for this long period, but I hope you enjoyed our cases.
Yeah, thank you.
Thank you so much. Let's see this case, this very nice case, and I think let's see. Here is this one. Okay.
Okay, can I request?
If you want to
sir,
scroll, go on. If you want me, yes.
I have requested
Free.
for the remote
Okay,
control.
go on. Okay.
Okay, these are CT head non-enhanced axial sections, brain window.
Okay.
I'm scrolling from down to the top.
Yes.
There are mild cerebral atrophic changes with prominent CSF spaces.
Okay.
I am looking for any other abnormality. In my first look, there is benign calcification of the fox
Okay.
along the anterior aspects. Now
Okay.
going down, I could not found any focus of hemorrhage or edema or mass
Okay.
lesion on my first row.
Okay.
Now I'm looking at my review areas.
Okay.
I think there is prominence of the internal
It's
development.
prominent, but it's not dense. Okay.
Okay.
Yes.
Yeah, it's prominent.
Okay.
Prominent.
I'm sorry. Can you go to the coronal plane? Maybe helpful for you to pick up any abnormality, because it's for a little bit difficult and needs more time. But okay, go on.
Okay.
You can scroll now.
Yeah, I can scroll. Okay, I'm looking at my review areas. I think there is on the right side. I can appreciate in the right paracellular region.
Yeah.
There is asymmetry on the right side as compared to the left side.
Yeah.
So I will like to see this on the bone window, also on the post contrast images if available, and also I would like to take the history of the patient regarding this could be some bony abnormality or associated soft tissue component.
Okay.
Or other, it could be some. I'm looking at the optic.
Yes. Well done. Really, you picked up the abnormality rapidly.
Yeah.
Can you please return back to the axial plane again? I think we can move here. Is it present in the axial?
Yeah.
Yes.
On the right side.
On the right side. Yes, you are right. Okay. What's your differential diagnosis?
Yeah, my differential diagnosis in this case would be a meningioma. Other differentials in this case would be some pathology related to the optic nerve, however less likely. Other differentials
it's a little bit far away from the optic nerve.
Yeah. Other differentials include metastasis.
Yes, metastasis.
And some other abnormality from the bones.
Yes.
So I
could
will
be aneurysm.
Could be aneurysm of the
aneurysm.
Yeah, sacral aneurysm. However, but I like to see the contrast enhanced images if available, or MRI.
Okay. MRI.
Also,
okay. I will give you the MRI. Thank you. Just a minute. Really, we did for the case MRI, and I think.
Okay, in this contrast enhanced T1 mated MRI images of the brain, I can appreciate that there is intensely enhancing lesion along right paracavernous location.
Okay. I think it is superior to the cavernous sinus. This is the site of the cavernous sinus.
It could be supraclinide in the region involving the region of supraclinide portion of internal carotid artery.
Yeah, I think it's also dural based and extraaxial and based along the anterior clinoid process.
Yeah.
Yeah.
So this has also irregular surface.
Yes.
And it is large in size. I need to look for the status of the right MCA.
Okay. I think this is the MCA. This is MCA. And this is the mass.
It looks fine. Okay.
Yeah, it looks fine.
Okay, so in summary, there is intensely enhancing vascular mass along the right paracavernous region, likely in the region of supraglenoid portion of internal carotid artery. This likely represent aneurysm.
Do you think it's aneurysm?
Yes,
I think it's a solid enhancing mass.
Yeah, sorry, it could represent meningioma.
Meningioma, you are right. Okay,
Yeah.
so as the differential diagnosis in this case, maybe secondary, maybe metastasis, maybe any meningeal masses, but the meningioma is the most likely diagnosis, and I think MRI can confirm this dural-based mass proved to be anteroclinoid meningioma. Okay, thank you so much. Candidate number 9. Let's go by our last case, candidate number 10. Where is candidate number 10?
Yes, doctor.
Candidate number 10, how are you?
Hi, I'm good. Good evening, doctor.
Okay, you waited too much. I'm sorry again for you, but I hope you enjoyed our cases. This case, I think I reported this case 2 years ago, but let's, because it's an interesting case really, but if you want to scroll, go on.
I think can doctor scroll for me because I think
no problem. Okay.
Yeah. Okay. So I have here a CT abdomen, sorry, a CT head axial cut.
Yes.
I can see diffuse cerebral atrophy, and as well as the ventricles appear dilated symmetrically, and the areas of well-defined hypodensities at the right.
Okay.
Right lentiform nucleus, or in keeping with O infarct. I don't see any other.
So we have something like all small infarcts.
Yes.
And the corona radiata, and I think extending to the right basic ganglia. Okay. We have also like brain involution changes for a little bit. Okay. Do you have any more abnormalities?
I see. So I can appreciate at the left CP angle, the left.
Yes. Okay.
Heterogeneous appearing mass.
Yes.
Causing mass effect onto the left pons. Also, it seems to be going into the left IAM, I suppose.
Okay.
In my usual practice, I will.
Do you think it's extending into internal digital canal?
But there's no widening. Yeah, actually, there's no widening.
I think the internal digital canal is totally free. It's not widened.
I see. Okay. So in my usual practice, I will do a contrasted study for this.
Yes, you are right. Unfortunately, I don't have contrast enhanced study because when I report this case, I requested to do contrast enhanced MRI or at least CT scan, but really I don't have. The patient didn't compete with me. But what's your opinion? What's your differential diagnosis in this case? Because this case is interesting case.
I see. It's still left-sided. Can I still call it a CP angle tumor? But it doesn't involve the IAM. Doesn't cause widening of the IAM.
Yes.
It appears extra-axial.
Appears extra-axial. Totally agree.
And it appears heterogeneous with
heterogeneous, yes, soft tissue mass, heterogeneous, indenting the left middle cerebellar peduncle and indenting the left cerebellar hemisphere. Agree, totally agree. I think also the mass lesion. Can I show you the bone window? Maybe helpful for you.
Yes, thank you. Okay, in the bone window.
Yes.
This also appears to be at the left mastoid air cells at the area of the region of interest of the lesion. There appears to be bony erosion.
Okay. We have bony erosive changes.
Yeah, it
along
appears
along the posterior aspect of the left petrous bone.
Yeah, bony changes with
changes. Okay.
Fluid with some fluid in the left mastoid air cells.
Okay.
However, I think the IAM is still not widened intact.
Agree.
Internal ear ossicles are also appears grossly normal.
Yes.
So this lesion appears at the left left CP angle with aggressive features.
Aggressive features. Yes. You have here aggressive soft tissue mass lesion along the posterior aspect of the petrous bone, left petrous bone. What's your differential diagnosis?
My differential would be Sorry, doctor, I'm not so sure what I can.
Can I help you, please? To conclude, what did you say? I think you mentioned or you described the mass lesion in the soft tissue window very well. I would like to add some important tips here. This is the fascia canal.
Okay, yeah, the fascia canal.
This is the intracranial part. Okay. And I think we have also this is the tympanic portion of the fascia canal, and I think also we have this one is the mastoid portion of the fascia canal. If you follow the mastoid portion of the fascia canal, you'll find that the soft tissue mass is extending into the mastoid air cells and involving the mastoid portion or invading the mastoid portion of the fascia canal. The cochlea is clear. The vestibule is clear. Semicircular canals are clear. We don't have any fistous communication. The oscars are clear. Any mass lesion involving this area, posterior aspect of the petrous bone, you should think of endolymphatic sac tumor. Okay, endolymphatic sac tumor is very important, and this is characteristic sign of the endolymphatic sac. If you, I want to show you, this is the endolymphatic duct at the right side. I think in this case it's very difficult to see it. I will show it to you in another CT scan of the brain. Please keep with me. Because this one, if you go to another case of CT brain, for example, this one, yes, look for this area. Look for this area. This is the endolymphatic duct. Okay, yes, this is the site of the endolymphatic duct and sac. Okay, and in our case, I'm sorry to let me wait.
No worries.
Oh, sorry. Yeah, let's again. So we have here this mass lesion is centered upon the left aspect of the petrous bone, centered upon the left endolymphatic duct, and this one most likely to be endolymphatic sac tumor. Once we have something like this, metastasis is one of our differential diagnoses, but once we have endolymphatic sac tumor, you should think for von Hippel-Lindau disease, and you should make a scan. Yeah, you should make a scan for the abdomen, searching for any renal masses, renal cell carcinoma, renal cyst, pancreatic cysts, pancreatic masses. You should do a scan for the abdomen to check if there is any possibility for von Hippel-Lindau, and also you should check the eye globe for any retinal masses. I think we don't have any retinal masses in these cases. And just to conclude that most likely this one is endolymphatic sac tumor because of its characteristic location. Okay. Thank you so much. Thank you so much, and I hope you enjoyed our cases today. I would like just to emphasize that we have multiple videos that help you in your routine life and routine cases, and also in FRCR exam. You can see our VIVA sessions free on our YouTube channel. Also, you can watch standard FRCR approach, and also you can watch emergency CT brain course. We have full emergency CT brain course in our YouTube channel, and I'm happy to see or to receive your comments, positive or negative comments. I hope you enjoyed our session, and thanks for all candidates who interact with me. Thanks for all audience. Thank you so much.